All right, if you're in nursing school, you know that managing a patient in renal failure is a huge deal. And right at the center of that is a procedure you absolutely positively have to know inside and out: dialysis. So let's break down this life-saving treatment into the key things you'll need to know when you hit the floor. Before we jump into all the mechanics and the different types, let's start with the big picture, the why. Because everything we're about to talk about comes back to this one simple but powerful goal: restoring the body's natural balance, its equilibrium, when the kidneys just can't do their job anymore. So here's our game plan. We'll start with that goal, then we'll explore the two main types of dialysis: peritoneal and hemodialysis. After that, we'll get into the patient's literal lifeline, their vascular access, and we'll wrap it all up with a quick knowledge check to make sure these concepts really stick. Okay, section 1. Let's get into the nitty-gritty of when a patient actually needs dialysis. Because as the nurse, you're the one on the front lines, watching for the signs that tell the whole team it's time to step in. So what are these triggers? What are we looking for? Well, we're watching for critical lob values that are basically screaming that the body is overloaded with toxins. A blood urea nitrogen, or BUN, over 90, that's a huge red flag. A creatinine level over 5, same deal. We're also on high alert for dangerously high potassium or hyperkalemia, which can trigger deadly heart rhythms. And then there's severe fluid overload that just isn't getting better with diuretics, or even certain drug toxicities. These are the signs that the body is in serious trouble. And that leads us to the official definition. Dialysis is the process that essentially takes over for the failing kidneys. And it's not just about filtering out junk. It's about fine-tuning everything, correcting those electrolyte and acid-base imbalances to pull the patient back from that state of crisis. Now, how do we actually do this? Well, there are two main roads to get to that goal of equilibrium. We can either use the body's own internal lining, that's peritoneal dialysis, or we can use an external, man-made filter, and that's hemodialysis. Let's dig into both. First up, let's talk about peritoneal dialysis, or PD. This one is pretty cool because it actually uses a part of the patient's own body as the filter. So how in the world does this work? Well, a special fluid called dialysate, which is full of dextrose, is pumped into the patient's belly. The lining of the abdomen, called the peritoneum, acts like a natural filter. Waste products from the blood are drawn across this membrane into the dialysate, and all that dextrose in the fluid acts like a magnet, pulling excess water out of the body. Then you just drain the fluid out, and it takes all that waste and extra water with it. Pretty clever, right? But, and this is a huge but for your nursing practice, because you're accessing a sterile space over and over again, the number one risk, the biggest, scariest complication you have to watch for, is peritonitis. That's a really serious infection of that peritoneal membrane. Okay, let's switch gears and move on to our second path, hemodialysis. This is probably what you picture when you hear the word dialysis, the big machine that acts as an artificial kidney. And this diagram shows you the whole circuit. The patient's blood comes out through their access point, gets pumped through this filter called a dialyzer, that's the artificial kidney part, and that's where all the waste and extra fluid get pulled off. Then the nice clean blood is returned right back to the body. It's like a big continuous cleaning loop outside the body. And just like PD had its main villain, hemodialysis does too. To keep the blood from clotting up the whole system, the patient has to be put on a blood thinner. So what's the major complication you're always on the lookout for? You got it, bleeding or hemorrhages. So, which type does a patient get? It's not a simple choice. It's actually a pretty complex decision based on a lot of things. You know, what's available at that hospital, how sick is the patient, what kind of access can we get, and, this is a big one, can the patient even be safely put on blood thinners? And this right here is the absolute non-negotiable rule for hemodialysis. There's no way around it. The patient has to be able to be anticoagulated, and the go-to drug for this is almost always heparin. Which brings us to a little pop quiz. This is essential stuff for any nurse. So your patient on hemodialysis starts bleeding, and you need to reverse that heparin stat. What's the antidote you're going to give? Think about it for a second. The answer is protamine sulfate. You absolutely need to have that one memorized. Now, for hemodialysis to even be possible, we need a really good, reliable way to get to the patient's blood. And this isn't just some minor detail, this is, quite literally, the patient's lifeline. So there's a definite pecking order for the best type of access. It's often called the fistula-first approach. The gold standard, the number one best choice, is an AV fistula. Second best is an AV graft.
And the last resort, because it has way more problems, is a tunneled catheter.
So what is an AV fistula? A surgeon basically connects an artery directly to a vein, usually in the patient's arm. That high-pressure blood flow from the artery makes the vein get bigger and tougher, so it can handle repeated needle sticks for dialysis. Now, your most important nursing assessment every single shift is checking to see if it's working. You do that by feeling for a vibration, we call that the thrill, and listening with your stethoscope for a whooshing sound, that's the bruit. If you don't feel the thrill or hear the bruit, that's a medical emergency. It means the access is clotted off.
Now, if a patient's veins aren't good enough for a fistula, the next best thing is an AV graft. As you can see here in the picture, a surgeon uses a piece of synthetic tubing to connect the artery and the vein. It does the same job, but it has a bit of a higher risk for clotting and infection compared to a fistula.
And for temporary situations, especially when someone is admitted to the hospital and needs dialysis right away, doctors can place big central catheters in the subclavian or femoral vein. For longer-term catheter use, they can use tunneled catheters in the jugular vein. But again, these are the least favorite options because they're basically a direct highway for bacteria from the outside world right into the heart, carrying a huge risk of deadly bloodstream infections.
Okay, we have covered a ton of information, so now it's time to lock it all in with a few quick-fire questions to check your clinical knowledge. You ready? First question. Your patient is on peritoneal dialysis. What is the single biggest, most dangerous complication you're constantly on the lookout for? You got it, it's peritonitis.
And what about the other side of the coin? For your patient on hemodialysis, the one getting heparin with every treatment, what's the #1 risk you're watching for? Yep, hemorrhages or bleeding. All right, last question, let's bring it all home. You walk into your patient's room. They just had an AV fistula created 2 days ago. Before you do anything else, what is the one key assessment you need to do on that arm to make sure their new lifeline is working? The answer we're looking for is you are feeling for the thrill and listening for the bruit. Mastering that simple assessment is one of the most important things you can do to keep your dialysis patient safe. And that's your guide to the essentials of dialysis.